available in archive format very shortly. So with that, I'm honored to moderate this closing panel that's looking at how we implement mitigation strategies to protect the hard-won gains we have made in relation to the HIV, TB, and viral hepatitis responses. We have spoken quite a bit throughout the conference about our deep concerns regarding what these disruptions mean, service disruptions mean, in terms of attaining the HIV 90-90-90, TB 90-90-90, and viral hepatitis elimination targets. And so I'm excited to welcome an incredible panel that represents public health expertise of wide range, starting with Dr. Renmin Hu, who's Assistant Director General at the World Health Organization for Communicable Diseases. He unfortunately is not able to join us in person for this session, but he offered this video for each of you to listen to and view.
Hello, good morning, good afternoon, good evening. I would like to thank the organizer for the invitation to join this closing panel. I really regret that I can't be with you today in person, but I'm so glad that I can share my presentation as a pre-record. I'll be providing a brief overview of the World Health Organization perspective of implementing mitigation strategy to protect hard-won gains in HIV, tuberculosis, and CV responses. This is status of COVID-19 pandemic of 7th September. Globally, there are nearly 27 million cases of COVID-19 and 880,000 deaths. The pandemic is being driven by the transmission in the Americas, Asia, especially in particular in India, and from the resurgence in Europe. From the epidemics, sir, it is clear that COVID-19 will be with us for many more months to come. And that is so important we understand how best to mitigate its impact on the essential health services of HIV, tuberculosis, hepatitis, and other very important comorbidities conditions. At WHO and around the globe, many groups has modeled the impact of service disruption on the future outcomes of HIV, tuberculosis, hepatitis, malaria, and other diseases. And the outcomes are clear, with interruptions in the supply chain of ARVs and reduced test diagnosis and treatment of HIV, hepatitis, tuberculosis. Deaths will increase in 2020 and could draw back many years of health gains to the levels of deaths and new infections since more than 10 years ago. We have to act to safeguard our investments to ensure the healthy lives for all. To protect these public health gains, World Health Organization has fully developed a comprehensive guidance of COVID-19 response to address the dilemma of balancing the needs and demands of COVID-19's response versus strategic planning to ensure that the most essential life-saving health services continue. The guidance from the World Health Organization outlines the basic principles and practical recommendations that support decision-making to ensure that the continuity of essential selected services for health, outlining the key actions that the countries should consider. The WHO documents focus on the disease-specific areas of working, including HIV, hepatitis, and tuberculosis. These recommendations do not replace the comprehensive programs guidance, but highlight the areas of programs that needs to be implemented, and others can be put on the pause and restarted when delivery can be done safely. In particular, all the activities described below should be implemented in a way that is fully consistent with up-to-date WHO guidance on IPC. In general, when the program's activity is not mentioned and can be delivered safely, it should be continued in accordance with existing guidance. From the WHO side survey on the services disruption across 91 countries, the major challenges reported was related to the decrease in the volume of the clients attending to the health sectors, and likewise, the deployment of many of the frontline health staff to work on COVID-19. Fear and the lack of PPE among health and community health workers also may be an issue. And this survey has looked for innovative approaches to mitigate these effects, such as using telemedicine, task shifting, improved and local PSM and community support and community-based service delivery. Already, more than half of these survey countries are using these approaches, which is great to deliver care. Lastly, across the board, we must remember that mental health as a baseline need for all clients to maintain critical health services. For this year's Mental Health Day, on the 10th of October, WHO, together with our partners organization, is calling for a massive scale-up in investment in mental health to make sure that all the people can have access to mental health services during this time of COVID-19. To wrap up, I would like to remind you that the World Health Organization is working to rapidly and actively scale up the response to COVID-19 through the ACT Accelerator and the COVAX. These investments bring many partners together to prioritize access to vaccine, therapeutics, diagnosis, while strengthening the health systems to deliver these tools. WHO, like many organizations, are boosting our efforts in the countries to support those most in need. With this, I thank you and wish you an excellent panel discussion.
Our thanks to Ren and World Health Organization for their participation at this year's conference. Yesterday, we heard from Meg Doherty, the Global Director of HIV, Hepatitis and STI programs at WHO, and so we're grateful for their engagement. I'll now introduce our panelists and ask each of them, after I introduce them as a whole, to deliver some opening statements before we get into a moderated discussion. I'm very honored to introduce Solange Baptiste, who's the Executive Director of the International Treatment Preparedness Coalition, Dr. Shannon Hayter, who is Deputy Executive Director for Programs at the Joint United Nations Program on AIDS, or UNAIDS, Dr. Ricardo Leita, who is the founder and president of UNITE, Peter Sands, Executive Director of the Global Fund to Fight AIDS, Tuberculosis, and Malaria, and finally, Dr. Anjali Anshkar, who's the Principal Deputy Coordinator for the U.S. President's Emergency Plan for AIDS Relief. So with that, I'll ask Solange to start with her opening statement.
Hi, everyone. Good day, and thanks, Jose. Thank you very much for the opportunity for ITPC to bring remarks at the closing of the virtual Fast Track Cities conference today. As we speak, we're losing ground against HIV, TB, and viral hepatitis because resources are being diverted to the global COVID-19 response. Although a loss of gains is inevitable because of the public health emergency, how much we lose is up to us. We must seize this unprecedented opportunity to transfer knowledge, skills, and infrastructure from HIV to develop a multi-pronged strategy across all actors and across all diseases to safeguard and continue our progress. Without a holistic approach, we are doomed to repeat the same mistakes while preventable new infections and needless deaths occur. As we try to stabilize our world and recover from the acute shock and ripple effects across systems, we have to ensure a few things. And I'm going to list 5 key points that I think we should all reflect on. The first is that we should limit the implementation of predominantly COVID-19 only solutions. Instead, we need comprehensive and integrated interventions. It is insane that we live in a world where a machine capable of diagnosing multiple infections is used for a single disease because the cartridge was bought using money from that disease's donor. Why have we not addressed this as yet? Furthermore, today, that same machine is now overrun with COVID-19 testing at the expense of HIV and TB. We need to reverse this trend now and quickly. Secondly, we need to address the non-biomedical root causes of disease outcomes. What accounts for the fact that Black people are 4 times more likely to die from COVID-19 than white people? Are Black people genetically predisposed to COVID-19? Even if biological differences play a role in health, inequalities, systemic racism, and other social factors have a huge impact, and we can address them. Social determinants of health are a major driver of morbidity and mortality as the world grows more and more unequal. We need to address the causes of risk, vulnerability, and transmission at a structural level. And remember that people are not high risk, situations are. Focusing on structural and socioeconomic drivers is a win for everyone. It helps to address HIV, COVID, Hep C, TB, and many other non-communicable diseases. Just think about it. Today, in a post-apartheid South Africa, townships are hotspots of COVID-19. But if we enacted better housing policies, we could address both COVID-19 and TB. What about better policies to improve the availability of healthy food? These would reduce cardiovascular disease, save lives from heart disease and diabetes, and create more resilient populations, not only for this pandemic, but for future ones. My third point is on stigma. We have to seriously tackle stigma, not just capture it and call it out, but intervene. Spraying people with trainings doesn't change their deeply entrenched beliefs. More data will not change your uncle's belief about that bad person. Socio-behavioral or social behavioral interventions and health education have their place, yet they seem to have taken a backseat to the biomedical silver bullets, leaving stigma a pervasive and lethal barrier to health despite medical advances. Stigma blooms in environments of low health literacy, misinformation, and disinformation, yet we scrape the bucket to find funding for this kind of work. Let's take our struggle to reach men. We speak about men being at higher risk for advanced HIV disease, which is AIDS, as if it was a biological predisposition, when we know the main reason is that they are less likely to engage with the health system because of stigma. Stigma has the power to cripple every single good thing we do in each disease. Let's work to prevent this from happening. Number 4, we have to address affordability head on. When will we stop using World Bank classifications to determine which country can benefit from pricing deals, as if rich and middle income countries don't have severe and widening inequity? The city of Moscow currently pays 60 times more than Kyiv for the HIV cure. Middle income countries are the hardest hit, yet their funding is subject to the harshest cuts. In response, we contort ourselves in the global space to accommodate rich member states and their pharma lobby in fear of backlash, and barely fund the strategies that we know work, like TRIPS flexibilities, including, dare I say, compulsory licenses. We know in our gut that quality healthcare should not be linked to having a job or determined by market forces. And for my final point, we will need to build community systems. Build them to be more resilient to future shocks. COVID-19 is just the start, given the state of our world. After spending hundreds of millions on studies like pop art and others, we know that strong community systems result in better health outcomes. So how well are we investing in communities? We are up to our ears in member state commitments. We have a brilliant commitment to ensure that by 2030, at least 30% of all service delivery is community-led, and community-led, not civil society-led. Yet up to now, we don't have a shared definition, and apparently we cannot track how much funding goes to community-led responses despite their contribution towards achieving global health targets. And so here we are. None of my 5 points are surprising. No silos, deal with root causes, address stigma, dismantle affordability barriers, and build communities. Yet we've been grappling with these points for over 3 decades. So what's the issue? What's the real barrier? What's the barrier to real action? Something is wrong with how the current system is set up. Build it and they will come, right? But everyone is not coming. That mentality is of the old guard. Colonial, paternalistic, over-medicalized, top-down, I know what's good for you, so you come here. COVID demonstrates that we can change. All of a sudden, multi-month dispensing is the norm, not just for ARVs, but for other chronic decisions. Even telemedicine has been scaled up. The future requires that we foster supportive self-management and truly detach ourselves from the notion that quality healthcare must be at the clinic with a medical doctor. It is 2020. School is happening at home. This virtual conference is happening at home. Shopping is happening at home. Work is happening at home. We need better strategies for delivering healthcare outside of the clinic. We have strong examples of community responses ranging all the way from home-based care for AIDS, all the way to simple no-touch hand-washing gadgets in villages. This is how we can use a co-designing approach to best meet the needs of people where they are. Each of the 5 points I've raised could drastically improve if we seriously redistributed resources to strengthen and integrate community responses into our collective effort, because we all know the exponential return on good health outcomes when communities participate in design and delivery. Despite calls to reimagine systems for health, there is no incentive for the established system to relinquish power. Public health is political. Good public health requires good leaders, and good leaders require an activated civil society to elect them and hold them accountable for safeguarding health as a right, not fluffy nice to haves, but an enforceable constitutional right. And an activated civil society requires deliberate investment, development, and access. And let me repeat myself for those whose connection may have dropped. People, civil society, and communities must be where we invest. Inherent in the principles of the Fast Track Cities initiative is the fact that the whole is made up of the sum of its parts. To effectively mount an attack on a global and national level, we need to tackle epidemics at the city and the local level, and the strategy is working. So as we think about safeguarding the gains of the past decades for HIV, TB, and HCV, and we think about the geopolitical antics of the rich, the powerful, the high caste, the real change lives in the local, people-centered response. If there is no incentive for the established system to relinquish power, it will be taken by the people. Thank you.
Thanks, Solange. I think I am next. This is Shannon, and just wanted to add some thoughts about how we need to be thinking about resiliency and what we need now for what we need later. Not just to get through this COVID time, but to be better prepared for the next pandemic when it comes along. And I think to carry on a theme that Solange started, that, you know, cities are really critical in this, and it's not just because we're at a cities conference. Cities will always have a unique place in pandemics. We know for pandemic severity and growth, cities are very different environments. We've got concentrations of people in close proximity. This is true for COVID, but not just COVID. When Ebola suddenly became an outbreak in a, you know, high concentrated trade exchange area, not in a rural area, what it took to control it, the intensity, the scale, the complexity grew massively. It wasn't going to burn out with minimal response. Second, to understand urban preparedness, we've got to recognize the multiple overlapping axes of vulnerabilities and inequities that we see so concentrated in cities. We see concentrations of people, concentrations of poverty, concentrations of marginalized status. This shows up in slums, in informal settlements, in work with migrants, with people who flee. And oftentimes these communities are not fully served by or have full access to the formal systems as they stand now, be it for health, be it for education, be it for justice, be it for human rights. And then I think finally, a lot of what you've talked about this last couple of days is the fact that cities also have a specific and unique ability to respond rapidly, to have more agility than we see at the national level alone sometimes. There is unique and concentrated political leadership, governance that's close to the people, concentrations of services and systems, and communities with linked and powerful and historical identities. The monies that are available and the authorities that go with those monies vary a whole lot and may rely greatly on domestic resources. You know, one thing I see very clearly from the UN and multilateral resources is so much of the time we're only working at national level, not drilling down to the city relationships. So that takes a little bit different effort to mobilize as well. But more often than not, cities have been the seats of innovation. And I think that's what we've heard about so much today with the examples from across countries, cities as the hotbed of solution and actions. And so as we look to the future, as we look to what we need to do now to both respond now and into the future, I think we just have to make sure we don't let the experience of the HIV response over the last 3 decades, the experience of combating both HIV and COVID now, go to waste. Yesterday, we launched, as UNAIDS, in collaboration with the launch of this conference, a new report, COVID-19 and HIV, 1 moment, 2 epidemics, 3 opportunities, how to seize this moment to learn, leverage, and build a new way forward for everyone's health and rights. This is talking about reimagining systems for health that are, in fact, optimally effective, accountable, have exactly what Solange described, have that reliance and connection with community leadership, the co-design in the future, and are sufficiently resourced. So I just really wanted to launch us with, I think, 4 themes on take home as we look at what we're learning now, what we still need to do better, and what we want to do in the future. 1, about rights and community. A fully effective public health response will always be a human rights-based response. We need to solidify expectations that restrictions are evidence-based, time-limited, subject to review, that they make accommodations for those with special needs and vulnerabilities, and that we have community-led leadership and positioning at all levels of the response from the beginning, something that we did not do right away during COVID. Second, we need to make sure that this is solidified so we don't see yet again, at the next time this comes out, a fear-based response that hypes up stigma, overuses force and criminalization, and doesn't engage the community early enough. Second issue, multisectorality. A pandemic, any pandemic, whether it's HIV or COVID or whatever is next, is absolutely a health issue, but it's also much more than just a health issue. We need to include health, but also social and economic supports in the response from the beginning. Mobilizing all sectors from the get-go has to be something we do effectively and even more quickly. Third, when it comes to disparities and inequalities, we need to invest now to decrease the disparities, decrease the inequalities that worsen outcomes. Whether this is access to health, universal health coverage, getting better outcomes now for obesity, for non-communicable diseases, for mental health, for other infectious diseases. Whether it is addressing inequalities in safety from violence or in access to justice, whether it is overcoming inequalities and social stabilizers like access to education, employment, income. We've got to address these now. We've got to have global solidarity for access, for vaccines, for treatment access, allocations that encourage shared intelligence, shared innovation, and ensure not just now in COVID, but are hardwired as we go forward, who's first in line needs to be driven by who needs these treatments, technologies, and vaccines the most, not necessarily just who's closest to the solution or who's richest. And then finally, I think a final theme is health is wealth. We need to keep local leaders, providers, and communities tuned in to invest in health and preparedness as a priority and not forget about it once we're through COVID-19. You know, given the economic crises that are happening worldwide, the toll that COVID is taking on the economy, I hear a lot about worry about the future of health and development funding, both from national accounts and also international assistance. I've heard preemptive messages about getting ready for austerity, getting ready to lower our goals and our expectations and ask for less. And yet we're experiencing the most concrete and dramatic example of, in fact, how health is wealth, how failure to invest in health is tanking economies by making things worse than they might have been otherwise. So I think we really want to promote that idea that as we look forward, resilience lies in investing in health now. We have to intensify our investments coming out of COVID-19, not draw them back. So maybe I'll pause there for now and I will hand it on to, I believe, Peter Sands is following me. So over to you, Peter.
Great, thanks, Shannon. And yes. I have to say, I just thought both what Solange and Shannon said, and indeed Ren, were brilliant. And I've been kind of real-time reflecting on how I add value to their very powerful sets of remarks. And I thought I would do two things. One is a bit more operational, talk about what the Global Fund, as one of the largest funders alongside PEPFAR of programs to fight HIV and TB, what we've been doing in response to COVID. And then secondly, to just share a little bit of thinking on some of the kind of broader strategic issues, I think, for the fight against HIV and TB in the context of the COVID response. The first point is that we took a view very early on that we needed to, in a sense, lean into what was happening with COVID. It was quite clear that there was going to be significant disruption. Others have shown the numbers and modeling and so on. We run a bi-weekly survey across all 100 or so countries in which we operate. Roughly speaking, 75% of them say their HIV and TB programs are experiencing disruption. It goes up and down a bit, and there are differences in intensity, but 3/4 of our programs are being disrupted either by COVID itself or by the public health measures taken in response. The second thing was we were acutely conscious that the lessons, the infrastructure, the capabilities of the fight against HIV and TB had a lot to bring, a lot of value to add to the COVID response. And we wanted to make sure we were leveraging that in the most effective way possible. So right at the beginning of March, we introduced a set of flexibilities within grant programs that enabled countries to use some of the money we had provided to adapt their programs, HIV, TB, and malaria, to purchase PPE, to procure COVID diagnostics and so on, and to strengthen their immediate response to the pandemic. And that had a capacity of up to 500 million. But we also knew that wasn't going to be nearly enough. So in April, we launched something called the COVID-19 Response Mechanism, or C19RM. As we stand today, we have deployed through those mechanisms $723 million into countries. And it's basically been in 4 different buckets. One is adaptation of HIV, TB programs, and malaria programs, actually. Second is protecting the frontline health workers through both training and the provision of PPE. Third is doing urgent fixes and reinforcements to health systems, such as supply chains, strengthening laboratory networks, or indeed, as Solange emphasized, the importance of community-led responses. And then fourth, assisting countries in their immediate COVID-19 control and containment interventions. And we've been significantly involved in the provision of diagnostic tests to many of the countries in which we invest. To give you a few examples of the kinds of things we've done around adaptation of programs, we've funded things like in Ukraine using couriers to deliver HIV medication so that people didn't have to come into clinics. In many places, we funded the shift to multi-month dispensing for both TB and HIV treatment. Big emphasis on training and procurement of PPE for health workers, and particularly outreach workers, community health workers, working with key populations such as sex workers, because often they get missed by the core PPE programs, which focus on hospitals and doctors and so on. And likewise, places like Uganda, we have funded the shift of prevention of mother-to-child transmission programs to being mobile, to being delivered door to door, instead of mothers having to come into clinics. As examples of some of the things we've been doing on the health system side, significant investment in strengthening laboratories. This is an interesting example of where the infrastructure put in place for HIV and TB has been used in the COVID response. So most of the automated PCR testing that's been done has been done on machines that were put there for viral load testing or for TB diagnosis. The trouble is it's been squeezing out some of the work that's been done on viral load testing and TB diagnosis. And so we've helped countries buy collectively across them several hundred new PCR testing instruments to expand that capacity. There's been a lot of use of moving things to digital or telephonic means. So virtual observation of TB treatment is just one of the examples, and also digital support systems for preventative TB treatment. There's been a huge amount of activity, and all of this has been very collaborative with USAID, PEPFAR, with countries on both tracking the risk of stockouts and taking action to mitigate it. So bringing forward orders, expediting shipments that are delayed by lockdowns, and also shifting stock where we see problems emerging. More generally, we are very watchful on the potential impact of COVID-19 on pricing and availability of essential commodities, because many manufacturers are switching capacity from HIV and TB and malaria to COVID-related medical products. So there's a huge amount of activity, and that's going on as we continue to support countries in their responses to COVID-19 and their adaptation of HIV and TB programs. But I do think this is throwing up some sort of bigger challenges, and I think the game is the challenge is actually shifting. To start with, early on, most of the disruption was due to the lockdowns. Now we're actually seeing much more disruption due to the spread of the virus itself. And that changes the emphasis on the kinds of interventions. For example, it puts a huge premium on PPE for protecting health workers. I think we're also seeing a shift in focus from what was seen as the immediate problem, which was disruption to treatment, to ART, to disruption to prevention. And I think we're going to need collectively to see a huge amount of imagination and creativity on an innovation around how we adapt prevention programs for different key populations, for adolescent girls and young women and so on, to a COVID socially distanced context, because so many of those sorts of programs are heavily reliant on face-to-face contact. I think the point that Solange emphasized around both community leadership, around stigma, around the root causes and inequalities, these I think need greater emphasis. Actually, many of the COVID-19 responses across the world have been very top-down and very medicalized, and haven't really been informed by an awareness of inequalities, of stigma, of the importance of community-led responses. And indeed, I think that's one of the things that the HIV community can bring to the COVID response, is the energy and the sense of how all of that works. When we look more fundamentally at how this is going to change the world of global health, I hope we can challenge a few things that are sort of established. And one of them is, frankly, the distinction between endemic diseases, such as HIV and TB, and new pandemic threats, health security threats. In most descriptions of health security, people don't talk about HIV or TB, yet they were once pandemics. They were once global health security threats. And the sort of harsh truth is that when they became less of a threat to people living in the wealthier parts of the world, they were no longer classified as being part of the global health security agenda. And I think we need to break that down. We need to think about infectious disease threats in a much more holistic way that doesn't draw a false distinction between the new threats and the ones that are still killing people all over the world, but particularly those who are the poorest and most vulnerable. And so we need to reframe the whole discussion around global health security, in my view, so that it doesn't just pick and focus on the threats that might be threatening to those in the wealthier parts of the world, but focuses on the things that are threats to people in whatever communities in which they live. I also think we need to make sure that the COVID-19 response, that success is not just measured, as it tends to be, on reducing the number of deaths or infections of those testing positive for COVID-19. Because certainly in many of the countries in which the Global Fund is most active, I think that the true cost of COVID, the knock-on consequences on other diseases such as HIV or TB, may actually outweigh the direct impact, not least because of the demographics mean that with many younger people, the effective mortality rate to COVID may be, we don't know for certain, but may be lower. So success in the fight against COVID-19 needs to be measured in terms of mitigating its total impact. It's absolutely no point to save somebody from dying of COVID-19 only for them to die of TB or HIV. I also think we should use the energy, the political salience of health that has come from COVID-19 to change the sense of urgency around HIV and TB. These are unfinished fights against pandemics that we should have finished years ago. So we need to think about the fight against COVID-19, not just as a fight against one particular virus, but as a fight against this new virus, as a call to finish the unfinished fights against the older pandemics of HIV and TB, and also a call to make sure through building more resilient health systems, through integrating community-led initiatives into the way health systems work much more effectively and pervasively, to make us stronger against future pathogens. Now, I noted Jorge had asked me a question, so I'm going to take the opportunity to answer this one immediately about whether or not the Global Fund is prepared to expand its mandate and be a financial mechanism to help prevent and prepare the world for future pandemics. It's a great question, and I don't know the answer, whether the board will be prepared to do that, but it is certainly a question that the Global Fund board will be tackling as it goes through its strategy process. And it's quite timely, it's a complete accident that the Global Fund strategy is being debated right now. And I would invite people who have a view on what the role of the Global Fund should be in this sort of broader agenda to make sure that their views are heard in that. there's no intent to have the Global Fund strategy be devised in a sense simply by the board itself. We very much want the views of the world on shaping the strategy on an institution which was created, when you remember, the Global Fund was created as the world's answer to what was the last big pandemic to hit humanity, and which we still haven't defeated. I'll stop there. And I think I've forgotten who I am handing over to. Am I handing over to Ricardo?
Yes.
Hello, and thank you so much, Peter, for passing it on. And I'd like to start by saying good morning, good afternoon, good evening to wherever you are in the world, and a special thank you to IAPAC and to my dear friend, Jose Zuniga, who I'd like to congratulate for their extraordinary conference. Being in Lisbon, Portugal, speaking from our national parliament right now, we were expecting to welcome you in person, but sooner or later, and sooner than later, we hope to welcome you here in our beautiful country, hopefully as COVID-19 subsides. And we are also very proud, and being here as the founding president of UNITE, the global network of parliamentarians to end infectious diseases. We are very honored to be partnering with IAPAC and with this Fast Track Cities conference, which is back-to-back with our UNITE Global Summit, which happened last Monday and Tuesday, and in which we were honored by the participation of Jose Zuniga in representation of IAPAC. And what I'd like to share with you is some of the takeaway messages precisely from that summit that I think relate very well with what we are discussing here today. Just on a personal note, to say that before I got involved into professional politics, I worked for nearly a decade as a physician in infectious diseases. And after I got into professional politics, shifting into public health, I got to work both at the national level, as I am now as a third-term parliamentarian, but also having been a deputy mayor of my town called Cascais, which is 200,000 inhabitants, not far from Lisbon. And out of those multiple experiences, I can assure you that working at the city level is one of the most demanding, because if things aren't going well, people will knock at your door. But it is also simultaneously one of the most rewarding, because here in Parliament, we can write all the laws we want. We can actually allocate resources where they are needed. But at the city level, if you decide to do something and you have the power to do so, you can actually make a change and see it immediately. That kind of reward is very hard to find in politics. But as I said, we need to work together, because also having this experience from the local and national levels, it is very clear to me that many times those that make decisions at the national or even at the multilateral level, the truth is we have a problem in trying to understand many times, if we are not connected with our constituents, with those working on the ground, what are the needs and realities, and what do we need to do as parliamentarians? Because parliamentarians are truly those that can make the difference in changing policies and changing laws, and being at that interface between the people and the national political power, and also representing our country abroad. But we also keep governments accountable in making sure that they are capable of giving the resources and the autonomy that cities need to act. And what we have seen throughout this crisis is that cities need that autonomy, that mayors actually can make a tremendous difference in pushing the 2030 agenda forward, and of course, fighting for HIV, viral hepatitis, and tuberculosis. So the 5 takeaway key messages that I would like to share with you from the UNITE Global Summit is first, that COVID-19 is clearly a game changer. And so the current pandemic poses an extraordinary opportunity to reinforce and redesign the global health order. And so investing on prevention and strategy is fundamental to lead the world in the direction to be better prepared for global emergencies. I think we all agree on this. Takeaway message number 2 is that we need a strategy for all infectious diseases, for all communicable diseases, and to ensure that no one is left behind. And it is absolutely true that across the world, we have seen on the ground in this unprecedented crisis that the world has responded with unprecedented global, but also local solidarity. And this kind of approach is needed for non-COVID responses and challenges. And from my experience, I honestly believe that mayors can actually lead the way towards making sure that that kind of solidarity, that kind of spirit of helping among institutions, among stakeholders, and making sure that our communities are resilient and capable to respond, making sure that community-based organizations and patient advocates have the tools they need. Cities can be the catalyzers to make sure that that reality is happening and is true. The third takeaway message is that science is the best shield we have for good health and well-being. And the truth is, neglecting research and development is neglecting the future of our children and grandchildren. We need to create good research and investment environments to reach our goals. And it's truly in our hand as parliamentarians to foster legislation for these collaborations. We truly have the responsibility of translating best practices, of translating scientific evidence, and adapting it locally to respond to the needs of the people. And what better way to do it if not making sure that we are capable of doing it in an articulate manner with the urban responses and urban leaders. The takeaway message number 4 is that we need also to turn threats into opportunities. And that means that we need to better respond to current, but also emerging infectious diseases. And within this group, we have to include, of course, HIV and AIDS, viral hepatitis, and tuberculosis. In terms of each of these areas of intervention of global health, we need to understand clearly, especially now, as we are in the midst of COVID-19 and thinking of the aftermath as the pandemic dies over. Where are we today and where will we be in terms of the response in each of these fields, from prevention to diagnosis to access to care and treatment? And that means that we have to go back to basics. Health needs to be present in all politics. And I think that now, more than ever, we are starting to get that political support to achieve what we have been calling for years. But I would say that health in all politics is not enough. We also need to have the budget to get the job done, which means that we have to have the capability of demonstrating how we're going to use the money effectively. It's not just a question of pouring the resources, it's getting the right outcomes from those investments. And the last takeaway message number 5, is that health is needs to be front of center of global development. I can guarantee you that there is nothing more important right now in the minds of legislators around the world than COVID-19. And for everyone, it is also clear that health is not a cost, but it should be perceived as an investment. Experience has shown us that after a crisis, people tend to forget this. And it is critical that we are capable of promoting the reforms that are needed as of now and making sure that people do not forget so that situations like the ones we are living never happen again. But we also need to make sure that this is translated into more holistic approaches, to more holistic policies. It's not just about health. It's about what kind of societies that we need. And so we actually need to make sure that we have to influence economic policies to be more focused on health and well-being, which means that looking at GDP for economic growth is not enough, because we know that countries can grow their GDP and while they are growing in terms of inequalities. We need to make sure that the economy of well-being of the future is capable of seeing economic growth for a country translating into economic growth for the people living on the ground, making sure that those in most vulnerable situations are the first ones to get the needed response. And it also is very clear today that health is a prerequisite for any economic development or growth, but it is also a prerequisite for any form of sustainable development, both at the national, but also at the local level. So I'd end here by saying that humanity needs global solidarity to aspire to a better future. And to do that, we need to keep on track in terms of the Sustainable Development Goals. Use those Sustainable Development Goals, use the beacon from the lighthouse that the Sustainable Development Goals can be in this time of darkness to make sure that we are keeping focus, both as national, multilateral organizations, but also as mayors, deputy mayors, and city councilors around the world to make sure that we are bringing together all the different stakeholders to make sure that we achieve the goals we had set back in 2015, which is to reach 2030 without leaving anyone behind. And I'll stop here and pass it to the next speaker. Thank you.
Thank you so much. It's a real pleasure to be with you today. My name is Anjali Achrekar, and I just, so many of the comments made prior by Ren and Solange and Shannon and Peter and Ricardo. I mean, so much of what has been shared, I think you'll also see ringing through when I provide the perspective from PEPFAR, the President's Emergency Plan for AIDS Relief. So I'm going to share some slides as I walk through this presentation. But first, let me just say thank you to Jose and IAPAC for inviting us to be a part of this panel. It sounds like the conference that you've had has been tremendous and so critically important. I also bring Ambassador Birx's well wishes. She is fast and furiously trying to address the COVID response here in the US. So let me share my slides, see if this comes through. Great. Again, just happy to be able to share a bit of the perspective from PEPFAR, what we've been learning, what we've been doing, how we've been adapting to really ensure that the hard-won gains for HIV continue. So a bit of history just for a moment. PEPFAR, the President's Emergency Plan for AIDS Relief, has really evolved over time. In the past 17 years, the US, as many of you know, have worked together with communities, together with multilateral partners, together with partner governments to really implement a global response for HIV and AIDS, starting 17 years ago and through to today. Moving from really responding to an emergency to save lives in the early days to then ensuring an AIDS-free generation, and now really accelerating core interventions to reach epidemic control. We've worked really to focus on three core pillars: accountability, transparency, ultimately for greater impact. And what's critical to this is really working through active program and partner management and really utilizing data for action down to the most granular level at the cities, at the communities where the people live. Over time, we've been seeing some tremendous success. These are country responses to where they are on the 90-90-90 goals. Again, really starting to see that countries are getting to a point of achieving epidemic control, reaching or getting close to the 90-90-90 goals, which is really outstanding and tremendous. PEPFAR program results, just to give you a snapshot of where we are at mid-2020, there are now 16.5 million women, men, and children that are on life-saving ARVs, over 3.5 million people living with HIV that have completed TB preventive treatment, nearly 25 million voluntary medical male circumcisions that have been conducted. We're providing critical support for nearly 6 million orphans, vulnerable children, and their caregivers. And we're seeing some real stark declines in HIV diagnoses among adolescent girls and young women, which we're really, really pleased to see. course, this does not happen alone. This happens in partnership with many of the people around the virtual table here, and in partnership with so many in the countries themselves. We've been focused on really ensuring HIT or high ART coverage, really recognizing that this is key to achieving impact, but that there is a comprehensive response focused on prevention activities as well as treatment activities. But what is absolutely critical, and I think we definitely heard this in all the speakers prior to me, that client-centered services is absolutely key. This is our path to epidemic control, listening to the clients, the people themselves, and acting. Really putting that public back into public health is critical. We know that this requires routine monitoring and really understanding barriers, enablers to accessing services at the client level, hearing from clients' perspectives, hearing from clients themselves. Communities and civil society are absolutely critical to this, and we've been working actively with communities on community-led monitoring, having them really participate in the response with us, helping to guide what that response should look like. And what we know, and we've heard the others talk about this so eloquently, that these challenges that COVID-19 has really shined a light on are really really tremendous and really exacerbated among the people that are living with HIV. Issues of stigma and discrimination, fear of COVID-19 keeping clients away from facilities, issues of, inability to be able to social distance when we're talking about high density cities, high density areas of living, informal settlements, overcrowded cities, et cetera. The broader issues of lack of clean water, food insecurity, serious economic considerations. And again, as my colleagues also shared, we fully agree and support that the response needs to prioritize a human rights approach, centering on evidence, empowerment, and full community engagement. Since the onset of COVID-19, we have been really working actively to do whatever we can to really ensure that we're able to continue services, both prevention and treatment services in the context of COVID-19, serving the clients where they are. We've been focused on ensuring continuity of care, leveraging PEPFAR-supported health systems and infrastructures, and I'll talk a little bit more about that. Focusing in on reducing exposure of staff and HIV clients to healthcare settings that may be overburdened and/or sources for potential exposure to COVID-19. And then, as Peter also noted, really looking inside to figure out how we can provide flexibility for programs to really ensure we're optimally serving HIV clients in areas affected by COVID-19. So sustaining collective gains in this COVID-19 pandemic has been our ultimate focus. And we know that in order to do that, and our ability to be able to do that has really rested on essential, deliberate collaboration with the Global Fund, with UNAIDS, and with the communities and the people that we're serving themselves. Engaging our US government-wide footprint that we have around the globe in 54 countries, working with the national COVID-19 responses, not just at the national level, but also down at the district and local level has been really critical. Something that's been tremendous in both in sustaining our collective efforts for HIV and TB have been the local partners that are on the ground. Those local partners, whether it's a natural disaster or a pandemic health threat like COVID-19, these local partners are on the ground, continue to be on the ground, serving the people. And so again, that relationship and fully funding local partners is something that has been critical. We've been working to figure out how we can strategically and intentionally leverage all this incredible health infrastructure that does exist, with over 3,000 labs and 28 national reference labs just on the continent of Africa alone, over 300,000 healthcare workers, including community health workers, to really figure out how do we, in order to protect the clients, in order to ensure continuity of HIV services, how do we also make sure that these healthcare providers are also working strategically on the COVID-19 response without detracting or diluting the response for HIV. If COVID-19, had any silver lining at all, we would say we've learned some really, important lessons that I think became more apparent in the HIV response because it really got down to, I think, what Solange mentioned so beautifully, which was really about health management. How do we work best to address what the clients themselves, the people, the communities themselves need in this particular environment to ensure that we're protecting HIV gains? So before the lockdowns even started, we worked really hard to figure out how can we best stay in touch with the clients themselves to really maximize retention. How do we ensure that we have contact methods in place, virtual platforms in place? What we've learned through COVID-19 also is that multi-month dispensing to ensure continuity of care has been absolutely critical. 3 to 6 months drugs, having access to 3 or 6 months of drugs of ART is absolutely critical. It works to decompress the facilities to keep exposure low of COVID-19 among people living with HIV. We've worked hard to decentralize drug delivery. How do we get life-saving treatment into the hands of the clients where they are, at the homes, closer in the community? There have been schools that have locked down. How do we work with schools to make sure that we can get drugs closer to where the clients are? The use of virtual platforms has also been critical, and this was mentioned by others. Telemedicine, and this is not just for the treatment program, prevention and treatment program across all of these areas. How are we using virtual platforms to really ensure that we are continuing to deliver critical interventions? And then empowering communities. Community-led monitoring, community-led programming, community-led service delivery has been absolutely critical. And part of that is leveraging the incredible work that community health workers are doing. And this is just one example that I wanted to leave you all with. This slide shows how COVID-related changes to multi-month dispensing policies in countries and where we've been working has really been, accelerated in the months since COVID has hit the ground. So this slide shows in blue how many countries, over 50% of these countries since March 2020, have really moved to increase multi-month dispensing and policies to best serve the clients. So again, the silver lining that we're seeing is that, if there's ever a silver lining, is that we are able to move faster to meet clients where they are, what they need, what the communities need to best ensure that services are continuing for them. And as I close, I just want to say, I think, Peter, as you noted, we are all working toward an unfinished fight. We are almost there with where we need to be with our HIV response, and this is a collective response. We have to finish this fight. So we are looking forward to working collectively with all of you to redouble our efforts, to redouble our commitment, and also learn, extrapolate lessons from what we're learning from the HIV response to other pandemic threats, but to finish the fight that we started. Thanks very much.
Thank you very much, Anjali, and thank you to all the panelists for your presentations. We have about a half hour, and I would like to get a question asked of each of you, but I'm going to have to ask you to please restrict your responses to 5 minutes or less if you can. Be succinct so we can get to everyone. So I'll start with Peter, who may need to leave us a bit early, but Peter, globally, we've seen major gaps in diagnostic capacity for COVID-19 and future emerging pandemics, as well as for HIV and TB during the COVID-19 pandemic. What can we do differently to test and find the missing millions of cases of TB and HIV in low and middle-income countries? And can this be done in a way that strengthens diagnostic capacity for future emerging pandemics?
Well, I think you're right. COVID-19 has been a wake-up call about the importance of both the science and manufacturing capacity for diagnostics, but also its importance in actual healthcare delivery. Those countries that adopted quite assertive testing programs early have basically done better in containing the COVID-19 pandemic. But there have been widespread shortages. There have been lots of issues about quality and access, and we are far from resolving all of those. And it's interesting because we are very deeply involved, the Global Fund, in the provision of COVID-19 diagnostics to countries, as I mentioned, and it's very challenging. It's very challenging getting sufficient supply of high quality diagnostics. And then also you run into capacity issues on the ground, i.e. the instruments on which PCR tests are run, laboratories, the availability of trained technicians and so on. So one thing I hope we take away from this is that diagnostics are incredibly important. And we kind of already knew that. I mean, the reality is having RDTs for HIV was transformational. The fact that we don't have RDTs for TB is one of the reasons we haven't made as much progress on TB as we should. If we had TB RDTs, we could make faster progress on containing TB as an epidemic. So I think the global health community has to take away the importance of diagnostics as one of the big lessons. And that will require people to think a bit differently about it. One of the things I've been very struck by in discussions around resource mobilization in the COVID context is all of it's challenging, but the story you tell about vaccines is a pretty easy story. Give people vaccines, they won't get the disease. People understand that. The story you talk about treatments is almost equally easy. Somebody gets sick, you give them a treatment, they get better, easy to motivate people to give you money. Diagnostics is a more complicated one because it's just whether you know they've got the disease, and it somehow doesn't come across quite as compelling as a story. But it is the absolute foundation. If you don't have effective diagnostics, as we have learned with HIV, as we have learned with TB, you can't really do anything else. It's the absolute foundation of fighting any epidemic. So we haven't solved it. There's a massive amount of investment and innovation around diagnostics catalyzed by COVID-19. But I hope we just don't forget that sort of when we get further into the fight against COVID-19, that we use that to rethink the global approach towards the importance of diagnostics and the role they play in our response to pathogens. And I'm afraid, as you say, I'm going to have to leave, but I've really enjoyed being part of this panel. There's been some really inspiring and insightful comments by my fellow panelists. Thanks very much.
Take care, Peter. Thank you. Anjali, I'm going to turn to you. So, there's been a confluence of border closures, lockdowns, and export restrictions that have led to significant supply chain interruptions for critical commodities, including ARVs, PrEP, PEP, condoms, lubricants, etc. So the case for global supply chains seems to be in question. What do we need to be doing differently?
Yeah, no, thanks. It's been something that we have been monitoring so closely. And as you rightly note, because of the lockdowns, because of, increased costs with freight, with ships, I mean, it's been complicated. And not just, and I want to say, not just getting into country, but then from country down to where the communities are. And so we have to be looking at it from all, the supply chain, but then also distribution of the supply. So, we have been, since the advent of COVID-19, just kind of projecting and watching numbers and seeing where things are going. We've been pushing for early orders. So we have been ordering and making, procurements much more frequent, much earlier than before, just to make sure that we would be ready for anything. And then I want to say, the other piece that's been critical has been the coordination with the Global Fund in all of this. I mean, we are working in lockstep to really make sure that if we're having trouble, they're picking up. If they're having trouble, we're picking up. It is, again, I mentioned this a bit earlier, but a bit of the silver lining in this COVID response is that our level of coordination has just, we've always been coordinated, but now it's just at a different level. It has been, we've really had to shift in this way. I think the final point is, again, the importance of multi-month dispensing, at least with ARTs. This has been critical, and we have been kind of moving buffer. We've been moving stock to make sure that we could accommodate that, because we know that above all else is going to be something, and has been something that we've been seeing that has been really critical to ensuring continuity of services and also protection from COVID. So again, I'll just, at that level, just leave it there.
Thank you so much. So,
hey, Jose, can I jump in? This is Solange. All right. On this question about supply chain, just because there's a question on the Q&A as well, I think it would be interesting to bring in I guess, the community perspective on supply chain issues and what it means for someone who's going to collect their medicine and not actually being able to get it. And the question here, I think, is from someone that's asking about the experience at the subnational level about equitable access and the supply chain and what that means. I just wanted to say that, from the community perspective, we've been able to pick up on this, as Anjali said, from community monitoring, right? And it's monitoring that had to be done, not people wanted to monitor because medicines were not available. And you'll hear, people talk about how much supply chain is fraught with corruption and what is really happening at country level. It needs to be called out. And so I think one of the sort of strategies that we need to take in combination with the global strategy is the ground up. What are we seeing and what's really happening, and being able to catapult that to the sort of community monitoring and advocacy for change. And I think another point that's related to this is with respect to local production. I don't know about you guys, but I started a herb garden because of COVID, right? I went to the grocery and some of the things I needed were not there. So dependency on imports in these times is a trap. And I think one lesson from COVID is that the entire world cannot rely on one or two countries for the supply of their medicines and other health products, right? Countries need to start thinking about self-sufficiency, and this goes along with promoting local production. But this obviously has another spin, right? We know that it will depend on markets and profit and geopolitics and trade negotiations. But I do want to make a call out to UN agencies and the WHO and the WTO to be proactive and provide guidance to ensure preparedness for countries who want to take this path of local production. And rich countries need to stop the pressure and the intimidation. Thanks.
Thanks, Solange. I think it's a nice segue into a question I had for Shannon, which is that, in many countries, there'd be virtually no HIV response without community-based and community-led services. Our ability to respond to pandemics depends on community as much, if not more. In some instances, the medical personnel, as Solange rightly stated earlier. What more should we be doing to strengthen this critical resource?
Yeah, we have part of our identity as the HIV movement being based in, you know, MIPA and JIPA, meaningful and greater involvement in people living with HIV and AIDS. And certainly when we talk about community-led roles, and by community-led, it's not just civil society. I think Solange said this earlier. It's about organizations and networks led by people affected by the condition for people who are affected. And yes, it's about the wisdom of the community. And yes, it's about the trust that communities members have through their own consistency, commitment, and membership in a community. But it's about way more than that. When we talk about how we bolster community-led role, it's not just anthropological, it's not observant, it is not community as informant only. It is saying, how do we ensure community-led organizations are key actors, players, and interventionalists? And what does it take to do that? And, you know, what we talk about a lot at UNAIDS is to say, you know, this means that we need to fight at governance levels to have direct, recognized, valued, non-optional roles that are connected to the formal system. It has to become part of the formal system. And we really focus, although there's tons of roles that can be played, we focus on three major categories of roles, and most of them have come up today. One is community-led organizations at the governance, policy, and planning tables from the get-go. We have this in CCMs, we have this in national AIDS councils. When we look across with COVID, this is one of the places where we've seen major gaps still of getting community-led organizations to the decision body tables, to the planning tables. So that's something we have to do better. Second category is what we look at is direct service delivery. And certainly we have seen many innovations at community level coming from community-led organizations who are providing direct service delivery, innovation, access during not just these times, but really stepping things up even more during these times. But also, as Solange mentioned, community-led monitoring, that's sort of the third category. And this is a watchdog role. This is saying, is what was promised being delivered in reality down my street or not? Or what are people's needs? And it's both monitoring, having a feedback loop, ideally both at service or program level, but also at political level, at local and national political tables for accountability. And so, you know, we want to see these elements put into even higher implementation during COVID, but also change the definition of what's required for a formal system for health in the future, that these are non-optional components, not any less optional than a primary healthcare clinic, having community-led engagement in governance, service, and monitoring. And so what do we need to do that, and to do that more? You know, we need to remove policy and regulatory barriers, and we need money. We need to finance it. So it's inseverable. We have seen in this difficult time policies that don't recognize community-led organizations as essential providers, so that their movements are restriction, or they're blocked from access to PPE or other tools of the trade. But we also see more commonly a lack of social contracting mechanisms so that governments can give monies directly to local organizations. And we've seen in some countries, at least one that I know of, community-led organizations that receive monies from international donors have to register as foreign agents. So there are real policy hostility barriers in place. It's not just an oversight in many cases. And then I think finally, and Solange has brought this a few times, invest. It takes money. We need to fund these roles for community-led organizations, including for more than just the direct service delivery role, for the governance and for the monitoring. We really need to get away from an idea that this should be volunteerism, that networks of some of the most marginalized communities and people in some countries are being asked to show up at every table for free. That's not sustainable. That's not part of a formal system. And frankly, the investment in the community-led as part of the core infrastructure, it is cheap compared to everything else we spend in systems for health. So that's sort of where I think we need to formalize, extend, and change expectations across the board.
Thanks a lot, Shannon. Solange, I have a question for you about the significant shift in the way that health services are being delivered as a result of restrictive measures with the advent of COVID-19. Much of the traditional face-to-face prevention and overall health information and promotional work has necessarily transitioned online. But how does this work for those who are not plugged in or are willingly unplugged?
Yeah, thanks for that question. As we all sit in plugged in, it doesn't work. It doesn't work for people who do not have the ability to get data, have reliable electricity for the cell tower to work, so the phone can be, data could be added to the phone so that you could actually hang on to a call. So this is, I think in COVID right now, we're doing the best that we can. There's been a ton of work done on the digital divide, and I think it's just exacerbated now, like everything else with the advent of COVID times. I do think that it is relatively the future, I mean, like the foreseeable future, because we have to find a way to make things work. And I think we want to remove the notion that doing things online is also cheaper. So you don't have to fly people in and you have a meeting in one space, but then online platforms require a lot of management. There's a lot of pre-recording and there's a lot of data and things you have to do behind the scenes. And as I'm sure, Jose, you're smiling, but the back end of this kind of thing is quite a heavy lift in terms of resources. So I don't think that it works. It doesn't work. So we have to find a way. Unless we will continue to build two worlds unless we insist on change. The digital divide has been there and it will continue to be there. And so we need to figure out a way around that.
Thank you very much. My last question is for you, Ricardo, and I want to acknowledge our partnership around Fast Track Cities, and thank you again for allowing me to speak to the Unite Summit. Very clearly the capacity to implement the international health regulations has been less than ideal, and I think it's contributed to suboptimal COVID-19 responses in too many countries. So my question to you as a national parliamentarian is, should the international health regulations be made enforceable with potential sanctions against any country that failed to comply?
Well, Jose, I mean, throughout the Unite Summit conference, we heard the example about air traffic control regulations, and the truth is, if global health were to be managed, if air traffic control were to be managed the way we manage global health, basically we'd have an air crash every 5 minutes. And the truth is, there was that pressure with air traffic control because lives were being lost and it was bad for business. So it was win-win to solve it. I don't think people understood that when it came to international regulation for global health, but things are changing. And that is probably one of the positive outcomes of this pandemic, that hopefully those that have the role at the national and multilateral organizations to finally understand that this is something they cannot ignore, that international development has as a prerequisite that we have these baseline rules that all comply with. I'm not absolutely certain that doing it in a negative way, creating punitive measures against those that do not comply, but trying to create possibly something different may help to make sure that countries stay in cooperation. One of the ideas that has been debated, and that was also debated throughout the summit, is that each country should have, as some already do, their own capabilities within their country in terms of responses to emergencies and biological threats. And having that, then we can create something like a NATO for health, in which each country has its own capabilities, and there's an international body that is capable of coordinating those actions in terms of operations. So if we think of WHO, it's a technical body, it's a diplomatic body. We're missing, in a way, an organization that has the capacity on the operations side and capable of making sure that those international regulations are somehow enforced and that we make the most of the resources, especially dealing with these cross-border threats, in which trying to think that we are isolated islands as nations is clearly a mistake. And so hopefully a solution down that path, some kind of new global public health convention must arise, and a new model, a new order for global health will forcibly, I believe, come out of this crisis. And I think that many of the institutions that already exist should play a leading role in starting the conversation now. This should truly be a never again moment in terms of pandemic threats in the future, because what happened with COVID-19 was our lack of capacity to respond in a timely manner to a threat, to contain it, which led to the situation we are living today. We have the knowledge and the resources to do better and to make sure that also these pandemic threats do not disrupt our well-being in the future.
Thank you very much to our panel. I'm honored to have moderated this panel, and thank you for your leadership as we all adjust to this new world, but also ensure that the continuity of HIV, TB, viral hepatitis responses is safeguarded. I'll just say a few closing remarks before we close our virtual Fast Track Cities 2020 conference, and thanking each of you for joining us. Again, I wish we were together in person in Lisbon, gorgeous city, but hopefully we'll be able to do so next year. From my perspective, I mean, I think the 2014 Ebola epidemic in Liberia terrified the world and revealed to us all how unprepared we were for an outbreak of an infectious disease. Where are we 6 years later, with too many countries still unable to mount robust responses to the COVID-19 pandemic, much less prevent them? Pandemic preparedness should rightly occupy the attention of the public health community, as well as our national and urban leaders, with communities at the center of every one of our actions. However, as we've heard, we cannot afford to 100% hijack infrastructures created over many years for mature epidemics, such as HIV and TB, without paying a steep cost in the lives of people living with HIV and other diseases. And as important, we can't siphon off funding for pandemic preparedness even as we confront economic recessions. So we're forced to examine our priorities. In my mind, surely we can prioritize realizing the right to health for all and the right to cities and municipalities as places that guarantee a decent and full life for all of their inhabitants. So my call to action to all of you is, let's make it our mission to safeguard our hard-won gains, but also prepare ourselves for future pandemics. It's not, to me, an either-or proposition. But as important, let us also ensure that we do not make the same mistakes again or accept the same trade-offs. We have to learn from what we are currently experiencing. Otherwise, we will prove true the definition of insanity, repeating the same actions, but expecting a different outcome. With that said, I thank each of you for joining us at the virtual Fast Track Cities 2020 conference, and hope to see you in person next year, March 22nd to 25th, 2021 in Lisbon, COVID-19 permitting. Thank you again, and be safe.
Thank you very much.